to introduce you today.
Excellent. Training back to patients.
I'm going to unmute this and go ahead and clip it on.
So this is unmuted?
It's going to turn the screen.
Okay. Do you need this to introduce me?
Nope,
I'll switch it.
Good afternoon, everyone. We are here for our second Lunch and Learn for April. Thank you for joining us this afternoon. And thank you for bearing with me, as this is not my forte, and by this I mean public speaking. I'd like to introduce Dr. Utay, who is our go-to expert for all things HIV and Hep C co-infection related. She has a doctorate from the Baylor College of Medicine, and she has been working in the field for quite a few years. She is here today to share her knowledge and wisdom with us. So without further ado, I'll let the pro give it a go.
Thanks, Brad. And thank you all for coming here. I think about half of you got here on Island Transit, like I do. So here are my disclosures. I'm going to talk about hepatitis C and HIV, and I've given these talks before, but really what's neat about this talk is that a lot of data have come out in the last year or year and a half or so specifically on co-infected patients, and so I'll present a lot of those data today. So first I'll talk about virology and epidemiology, just a little background there, clinical manifestations of hepatitis C, treatment regimens, relapse and reinfections, and drug interactions. So first, a little about the virology. Hepatitis C virus, it was isolated and identified in 1989. There are 6 main genotypes. It survives outside the body actually up to 4 days, particularly in a heavy loaded syringe of blood. So something to keep in mind about needle sticks. It's highly error prone, and like HIV, there's a rapid development of resistance, and about 85% of the virions, the virus particles, essentially are unique, and 85% of 10 to the 12th, you can imagine how many unique viruses are in the body. So 170 million people worldwide are infected with hepatitis C. This translates to 300,000 deaths worldwide annually. In the US, it's thought that there are about 3 million people and 400,000 in Texas. Most patients are so-called baby boomers. They were born between 1945 to 1965. 3/4 of them are unaware of their status. Most people are not screened routinely by their physicians, although the new guidelines suggest they should be. And before 1992, it's thought that the blood transfusion was a main cause of transmission, but also you can imagine people who were coming of age in the 70s. I'll say I wasn't coming of age in the 70s, but I understand that drug use was not uncommon, at least a little experimentation, and sexual activity was perhaps more active and before the HIV epidemic, and really emphasis on condoms with sexual transmission. That might have been another route of spread. It's currently the leading cause of liver transplantation in the US, and there are about 15,000 deaths a year in the US from hepatitis C. So what about co-infection? Well, it turns out, at least in the US, an estimated 1/4 of people with HIV are co-infected with hepatitis C. Now, of course, this is going to vary based on the demographic and the city and so forth, but it is actually quite common. And you can see that in terms of transmission on the right here, if you look at HIV exposure risk among co-infected patients, IV drug users, 65% of IV drug users are going to be co-infected with hepatitis C, compared to those who acquired HIV by sexual activity on the order of 15%. And surprisingly, a lower percentage of men who have sex with men have co-infection, although this is a risk factor. And in fact, the risk of transmission of hepatitis C by same-sex intercourse among men has been on the increase. And you can, I don't know if you can see here the years here, but starting at about 2000 or so, we really start to see an uptick in the number of, in the incidence of hepatitis C infection among men who have sex with men. Currently, it's thought that about 1.34 out of every 100 people, so I mean, it's hard to partition a person, but 1.34 out of every 100 people followed per year, or you can, do some fancy math, but essentially the risk of transmission has tripled between 1991 and 2012. And it's thought that this is attributed to more traumatic sex as well as methamphetamine use in bathhouses and at parties. So who should be tested? I mentioned the baby boomers, 1945 to 1965, and that includes anyone in the audience born in this age group. If you haven't been tested, talk to your physician. But also current IV drug users, injection drug users, even people who only use injection drugs once should be tested. Now, everyone who is HIV infected should be tested at least once. If they are engaging in unprotected sex with men engaging in unprotected sex with men, they should be tested at least yearly. And of course, if there are iatrogenic exposures, that would also be an indication for testing. Mother-to-child transmission is a possibility, although I don't think that translates to too many patients that we all see. So how does hepatitis C present? Well, acute hepatitis C infection is asymptomatic in 80% of people. Only about 20% of people will have symptoms. And these are usually occur about 6 weeks after exposure. They can vary anything from fatigue to some nausea, vomiting, hyperbilirubinemia, abdominal pain, and joint pain. And about 20% of people will clear the virus spontaneously, although the rate of spontaneous clearance is less in the presence of HIV infection. So what is the natural history? Well, first I mentioned people with acute hepatitis C infection. Actually, 20% will clear it, as I mentioned. And these people, when you test their blood, you not only have to test for hepatitis C antibodies, but you also have to test for hepatitis C RNA levels, because people who spontaneously cleared or who were successfully treated are still going to be antibody positive, but they're going to be RNA negative. Now, what about people who develop persistent infection? So this is the remaining 80% of people. These are people who are going to have detectable hepatitis C RNA levels. That's why it's important to keep this in mind, and especially as we're treating more and more people with hepatitis C, seeing their positive antibody is not sufficient to label them as having chronic hepatitis C infection. But of people with persistent infection, about 20% will progress to cirrhosis, and of those, about 20% will progress to end-stage liver disease or hepatocellular carcinoma. This translates to about 2 people out of every 100 people who are infected. But of course, if you work at CDC, you might think that the numbers are a little higher. There are some factors that certainly increase the risk of progression. HIV is one of them, which I'll show you in a little bit. Also, alcohol use will increase the risk of progression. The Hispanic population does tend to progress more rapidly to end-stage liver disease and hepatocellular carcinoma as well. And increasingly, we're seeing non-alcoholic fatty liver disease complicate liver disease and may also contribute to accelerated progression. So what about chronic hepatitis C infection? Well, typically we think of this all as asymptomatic, although if you really probe people, you can see that they'll attest to having some fatigue. They'll occasionally have some joint pain, some nausea, anorexia, muscle aches, arthralgias. And there's this poorly defined cognitive impairment that they may also endorse. About a third of people will actually have normal transaminases, normal ALT, AST levels. 2/3 will have elevated levels, but it's actually pretty unusual. Only about a quarter will have levels over twice the upper limit of normal. So you'll see these low-level elevations of ALT in the majority of people that you see with hepatitis C. So other manifestations of chronic hepatitis C that we see a little less often include essential mixed cryoglobulinemia, lymphoma. I've seen a couple of people who've presented with lymphoma and then diagnosed with hepatitis C. We see some people with renal disease, membranoproliferative glomerulonephritis, which I have a hard time saying. Autoimmune disease, we're actually testing all of our patients for autoimmune autoantibodies, and we're seeing a lot of them actually do have autoantibodies. They can also develop thyroiditis, so we do check our patients for TSH to look for evidence of hypothyroidism. We're not seeing that much, I'll say that. With regards to skin manifestations, you have to think about it to look for it, but actually I am seeing a decent number of people with porphyria cutanea tarda who come into the clinic, and lichen planus as well, and I'll show a picture of porphyria cutanea tarda in a minute. And diabetes actually is also associated with hepatitis C infection, and it'll be interesting to see as we treat more and more people how their insulin resistance improves with curing hepatitis C. So here's a picture of porphyria cutaneous tarda. You can see these hemorrhagic blisters here. You can see some scabbing over here, the lesions, some induration, lichenification of the skin as well. It has protean manifestations, but essentially skin lesions, particularly in sun-exposed areas, make us think of porphyria cutaneous tarda. So I mentioned that HIV is a risk factor for progression. Now, this is a little bit odd of a study because it looked at viremia, defined HIV viremia as over 1,000 copies per mil, which is a pretty low threshold for defining viremia. But in any case, you can see here, this doesn't work really well. The purple line, if you can see, the very bottom line on both graphs is what we see in terms of the time to hepatic decompensation and the cumulative incidence. And the bottom graph, the bottom line in each graph is the hepatitis C mono-infected people. There it goes. Now the top, plus or minus. So the top two lines are the HIV-infected people. And on the graph on the left shows viremic versus aviremic people, defined as more than 1,000 copies per mil. And you can see that even with aviremic people, they have a 65% increased risk of decompensating to hepatitis C at any given time after diagnosis compared to the hepatitis C mono-infected people. And the rate is even higher, 82% in people who are viremic. Similarly, people with lower CD4 counts under 200 actually have a 200% increased risk, so twice the risk of hepatic decompensation compared to HIV, or compared to hepatitis C mono-infected patients. The risk is slightly attenuated in people who have CD4 counts over 200, about a 50% increased risk, but certainly you can see, even in people who are on antiretrovirals, who have well-controlled HIV infection, they're still going to be at risk for hepatic decompensation. And actually, liver disease is gradually becoming one of the leading causes of death in people with HIV infection. So what about treatment? Now, sustained virologic response is the term that we use, although some people who in the hepatitis C field are finally starting to use the word cure. Essentially, sustained virologic response is defined as an undetectable hepatitis C RNA level after treatment. And usually, now the gold standard we typically talk about is the SVR12, which is the sustained virologic response identified 12 weeks after completing treatment. So for this study here, this is actually mainly done from the interferon treatment area. This is comparing the rates of the mortality rates at 5 years between people who achieved SVR, so achieved sustained virologic response, compared to those who did not. And if you look at the general cohort, the mortality rate was about 2% in people who achieved sustained virologic response compared to almost 8% among those who didn't. So essentially a fourfold reduced mortality rate at 5 years. Now compare that to the cirrhotic population, 16% among those who were treated and did not achieve cure, so to speak, or sustained virologic response, compared to a 5% rate of mortality in those who did achieve sustained virologic response. Now if you look at the co-infected population, at those who did not get treatment in the blue bar, or those who did not achieve sustained virologic response with treatment in the blue bar, you can see the mortality rate is quite high, 11%. But this rate actually normalizes to comparable to the HIV uninfected people with sustained virologic response. So it really drives home the point that people with HIV co-infection will dramatically benefit and have a dramatic mortality benefit with treatment. So speaking of treatment, what do we do? So the AASLD and IDSA, so the American Association of Study of Liver Disease and the Infectious Disease Society of America, have issued guidelines on hepatitis C treatment. And these are generally in line with the European Association, the study of the liver, EASL. And what they say is that treatment should be prioritized in patients at high risk for liver-related complications, including hepatitis C HIV co-infection, based in part upon those data showing such a dramatic improvement in mortality. Now, not all of the funders recognize this, but that's a whole other topic. So to understand how the direct-acting antivirals work, it's important to understand the hepatitis C life cycle. So hepatitis C, much like HIV, enters a cell through a receptor, although hepatitis C uses at least 4 different receptors to enter varying kinds. And then it is uncoated, so essentially the capsule of the virus is removed, and it frees up the RNA. So now we have the RNA that can then go to the endoplasmic reticulum, where it's translated into proteins. So the RNA is made into proteins, and these proteins help form the structure of the virus. Now the RNA will also undergo replication using its own enzymes, and together the RNA and the proteins will be assembled into the virion. Ultimately, once the virion is assembled, the viral particle will be released from the cell, and it goes on to infect other cells. Now, this has led to the identification of these different pathways in the host, or the hepatitis C, the virus enzymes that are required for these pathways, has led to the identification of drugs that will actually work to target these pathways. And much like HIV infection, because of the rapid development of resistance, one drug is not enough. So if you give just one drug targeting one pathway, like you give one NRTI or you give one NNRTI, it's not enough to suppress HIV. HIV will develop resistance and come back. Same with hepatitis C. So there are three key enzymes that are targeted. First, there are these protease inhibitors. The NS34 is the name of the virus protein. This interferes with the protein. Essentially, it breaks up this big polyprotein. The protease breaks up this big polyprotein to individual proteins that go into the virion. The protease inhibitor prevents that, much like the HIV protease inhibitors. Now, with RNA replication, there are very similar drugs. I don't know why this laser pointer just decides to work sometimes. But they're very similar drugs. They're nucleoside or nucleotide analogs, and they're also non-nucleotide polymerase inhibitors. And then there are these NS5A inhibitors, and this is a virus protein that is thought to be involved in virus transport and assembly. And there's also a set of inhibitors that interfere with these drugs, or interfere with this pathway. So here's a list of the current FDA-approved drugs, along with the different pathways, different parts of the pathway that they target. Thankfully, they took some lessons from the HIV literature and the HIV experience and gave the drugs of the same class similar suffixes, so we can remember them as more and more drugs come out. So the protease inhibitors all end in Previr, protease Previr. That's pretty easy to remember. If you can remember that the NS5B protein is the nucleotide or nucleoside sorry, if the NS5B is the RNA polymerase involved in RNA replication, the NS5B inhibitors, or the nucleoside, non-nucleoside inhibitors, end in Buvir, so NS5B, Buvir. So those are the drugs that interfere with RNA replication. And then lastly, the NS5A inhibitors. This is the protein that's involved essentially in shuttling the virus out of the cell. These end in Asvir. NS5A, Asvir, NS5B, Buvir, protease inhibitor, Previr. You'll see this over time as more and more drugs come out, which we expect them to. So this is a list of the current FDA-approved drugs with the price tag for a 12-week course, which is currently what's recommended for most people with hepatitis C infection, regardless of HIV infection. And I mentioned that at least two different aspects of the pathway have to be targeted in order to have the effective treatment. And you can see that some of these drugs, like the top two and the third from the bottom, so sofosbuvir, cimeprevir, and decladisvir, those are single drugs. They have to be combined. So usually it's sofosbuvir plus either cimeprevir or decladisvir. So that ends up being about $150,000 for a 12-week course. The rest of the medications typically end up being about $80,000 to $90,000 for a 12-week course, with the exception of Zapadier, which is albuspivir, grazoprevir, and that's only $54,000, so a good bargain. I'll talk about some of these drugs. This is essentially the order in which they were approved by the FDA. So you can see the prices are sort of starting to come down a little bit with increasing competition, although not as much as we would like. So how do we choose? Well, probably the three most important determinants of hepatitis C treatment are genotype, drug-drug interactions, and unfortunately funding is a big determinant in terms of which drugs people get and whether they can even get treatment. But we also look at the presence of cirrhosis, this may determine which drugs, particularly in the stage of cirrhosis, which drug we can use, as well as the duration of treatment. Also, treatment experience influences duration of treatment. Comorbidities like cardiovascular disease or renal disease. One of those drugs, Grizaprevir, Elbasvir, is the only one that's approved for people with end-stage renal disease, so that was a big advancement. And resistance mutations are really understudied, underappreciated. We don't look at them a whole lot, but we do look at them for one drug, Elbasvir, in terms of determining duration of treatment. It's not, the funny thing about hepatitis C is because there's so many unique viruses, there's so many unique, I guess, mutations that the virus can develop, and most of them don't actually impact treatment. There are a few that do and just really have indicate that longer treatment is necessary. So this is a brief overview of some of the key drugs that are currently approved for genotype 1 hepatitis C, which accounts for about 3/4 of hepatitis C in the US. And you can see that in hep C monoinfection, here is the column on the left, and this is the sustained virologic response after 12 weeks after completing treatment, and hepatitis C HIV co-infection. And you can see the response rates are tremendous. They are on very similar, 95 to 100% for all of these regimens, with no real differences between monoinfected and co-infected patients. So this is a dramatic improvement over the interferon era, when HIV co-infected people responded at a much lower rate. So first I want to talk about this study, Decladisvir plus Sofosbuvir for hepatitis C in co-infected patients. And Decladisvir is an NS5A inhibitor, so it's going to interfere with virus budding. Sofosbuvir is an NS5B inhibitor, so it's going to interfere with RNA replication. So this study randomized people to either Decladisvir and Sofosbuvir, and treatment-naive people to either 8 weeks or 12 weeks of treatment. There's been this whole push, well, in part because the drugs are so expensive, and the shorter we can treat, the sooner people can be off medication and say they're cured, and you save 1/3 of $90,000, that starts to add up to some real money. And then also the treatment experienced people received 12 weeks of treatment. Now, the inclusion criteria were pretty broad. Decladisvir actually treats all genotypes, so genotypes 1, 2, 3, and 4. People with cirrhosis were allowed to enroll in the study. I think they ended up being about 20% of people. They were treatment naive or experienced, and they could be on protease inhibitors, non-nucleotide reverse transcriptase inhibitors, or integrase inhibitors. So essentially, any of the antiretrovirals. Now, one interesting part about Decladisvir is even though there are drug interactions, the nice thing about Decladisvir is that the drug can just be dose adjusted based on interactions. It's not prohibited. So this is called the Ally 2. They tried to have all these witty names for all of the medications and different classes, and I don't know, they didn't excite me. But anyway, this is the Ally 2 study. And you can see that in the figure on the left, the SVR12, so 12 weeks after completing therapy, with both treatment experienced and treatment naive people, 12 weeks of treatment, dramatic SVR rates, 96, 98%. The 8-week treated participants did not do as well, 76%. And you can see in the far right what happened with these people. So essentially, this is all patients compared to just genotype 1, and there were 10 relapses in the people who were only treated for 8 weeks, compared to 1 relapse in the other 2 groups. So, it seems, and they tried to look at the, what led to the relapses. Were there any underlying host factors that might have contributed? And in this study, they did not find any. So it just seems that 8 weeks is not enough for many people. So what about Ladipasvir Sofosbuvir? This is the blockbuster drug for one drug company. I'm going to avoid mentioning drug company names, but this one was the first fixed-dose combination, 1 pill once a day, with or without food, and it was studied in co-infected patients, 12 weeks of treatment, and it was a phase 3 multi-center study. It's effective for both genotypes 1 and 4. The thing about this drug is it's not effective for the other genotypes. So genotypes 2 and 3, which account for about 1/3 or so of the population, this drug won't work for. So again, treatment naive, treatment experienced people were eligible. People with compensated cirrhosis were eligible to participate. They had to be virologically suppressed, HIV RNA under 50, CD4 count over 100, so pretty modest CD4 requirements. They didn't really, they didn't require a whopping immune system. And all of the patients were on tenofovir and emtricitabine plus either efavirenz, raltegravir, or rilpivirine. So pretty open criteria. And you can see overall the response rates were, again, beautiful, 94 to 100%. Now, I've been going to liver conferences for a couple of years now, and it's at the point that when these studies are presented, we yawn. Because another 95, 100%, because it's just over and over again. This is what people, the response rates that people are seeing with these direct-acting antivirals. But we shouldn't be so cavalier. It's great. So you can see also that regardless of whether people have cirrhosis, regardless of whether people have been treated, 95% or more success rate. The other thing about these sustained virologic response rates that are reported in the studies that I'll mention is that failures include not only people who relapse, but also people who have detectable viral loads 12 weeks post-treatment, could be reinfection, and also people who didn't have a lab done 12 weeks post-treatment. So people who were, who dropped out of the study, lost the follow-up, et cetera. So many of those, that 5% actually is not accounted for by drug failure, but by loss to follow-up. That's on the one hand. So in terms of, that points to the biological activity of the drug, that really they're quite biologically active. Now the flip side of it is this clinical study is not a proxy for real world. People who are in clinical studies, particularly these pharmaceutical-sponsored clinical studies, their study coordinators are going to be calling, come to this visit. They're going to be tracked down, hunted down, et cetera. And they might be compensated as well. And people are still not coming to their follow-up visits. So you have to think about that when you see these response rates. The real-world response rates, which is what a lot of people are studying now, may actually be a little lower because of patient non-adherence. That being said, most of my patients are so excited that their insurance company or Medicare or whatever will treat them. They come. So of the total 10 patients that relapsed, you can see the overall study numbers were quite high. All were Black race, so African or African American. They all had this unfavorable genotype, so CCTT. So this is IL-28B, which is it's a relative of interferon. So we used interferon, which induces antiviral pathways for a long time to treat hepatitis C. This is a relative of that. And so the fact that there is an unfavorable genotype suggests that the host immune system may be playing a little bit of a role in helping with sustained virologic response. All had hep C RNA levels over 10 to the 6th, so over 1 million. And most had genotype 1A, most were on efavirenz. This didn't reach, on the table on the right, you can see it didn't reach statistical significance as far as a risk factor for relapse. But you might ask why the Black race is a factor. It's actually because these unfavorable IL-28B genotypes are found more often in people who have African heritage. So it's actually a genetic factor. So the next regimen I'll talk about is the sofosbuvir velpatasvir. So this is one of the newer drugs that was approved. One of the nice things about this drug is it's the only one tablet once a day fixed dose combination that's effective for all genotypes. So I mentioned that other one, the blockbuster drug, but that's only effective for genotypes 1 and 4. This one will work for genotypes 2 and 3 as well. Broad inclusion and criteria, again, naive or experienced, about a third had cirrhosis, and CD4 count over 100, suppressed viral loads. So again, pretty liberal as far as HIV inclusion, although they did require suppressed viral loads. And here people were either on tenofovir or abacavir-based regimens with any NNRTI, PI, or integrase inhibitor. So pretty liberal as far as inclusions. And what you'll see overall is a 95% efficacy rate. And when broken down by genotype, 1A, 1B, 2, 3, 4, overall close to 100%. Now, what I'll say here is, I was mentioning earlier, these two 92%, I mean, those stand out like a sore thumb, right? Well, it turns out that 11 out of 12 people had responses. So 1 out of 12 people did not attain a sustained virologic response, and that was because one person was lost to follow-up. That's what LTFU stands for in this group, and one person withdrew consent. So essentially, it goes back to the factor it's more about adherence and continuing in the study than necessarily efficacy. So this is the drug that is currently approved by Texas Medicaid. It's the first-line hepatitis C drug for, according to Texas Medicaid, and at least 16 other state Medicaids. It's a little more complicated of a regimen to take, but it's paritaprevir with ritonavir, dasabivir, and ribavirin, also more complicated to say. It actually, as you can tell by the names, it includes an NS5A inhibitor, so it interferes with virus budding, and it contains a protease inhibitor, and it contains an NS5B inhibitor, so it also interferes with RNA replication. So it targets 3 different aspects of the viral life cycle. This is a study in HIV co-infected people, and it's called Turquoise. Why Turquoise? I have no idea. But it's called Turquoise, Turquoise 1. There's a Turquoise 2 as well. I think there's also a Turquoise 4. In any case, so this is the abbreviation they use for the drug. They randomize people to 12 weeks or 24 weeks of treatment. They could be on atazanavir or raltegravir, had to have suppressed HIV RNA levels, a little higher CD4 count, over 200, and they did allow people with cirrhosis to enroll. And what you can see here is at 12 weeks, after completing therapy on the right, 4 weeks after completing therapy on the left, there's overall a pretty good success rate, 94%, 91%. Now, a couple of these were due to people not following through on the study. There were 2 virologic failures, one who relapsed after completing therapy, a 12-week course of therapy, another who actually broke through, became viremic while on treatment in the 24-week arm, and 2 of these people also developed reinfection. So they actually were infected with a different genotype during the course after completing treatment. So that accounted for some of the lower numbers observed as well. So here's Turquoise 1, Part 1B. And the reason for doing this is specifically in people who are taking darunavir. So in some PK data initially that pharmacokinetic data that they did, they showed that this regimen this hepatitis C regimen decreased darunavir levels by about 50%. And so they were concerned that this drug may not be effective in people who are on darunavir. So they randomized people to either maintain darunavir once a day, and then they'll stop their ritonavir that's used with the darunavir and use the ritonavir that comes with the hepatitis C treatment regimen. Instead, it's the same dose, or they switch to darunavir twice a day. And essentially, what they saw was 100% efficacy rate. So SVR12 of 100%. You can see the number of people was small, but overall, no one lost to follow-up. Everyone responded. Everyone had a suppressed viral load. There were a couple HIV blips during the course of the study, under 200 copies, but also they were monitoring HIV RNA levels every 2 weeks, which is more than we do in the clinic. And so apparently among other similar studies of people with HIV infection, it's not out of the ordinary as far as what they saw. So what about this other drug? So elbasvir, grazoprevir. This is the one that can be used in people with end-stage renal disease. And again, boring, 96% efficacy rate. Beautiful. But there were actually 10 relapses in this study as well, and 5 relapses and 2 reinfections. Overall, these are people who are on maltegravir, dolutegravir, or rilpivirine. But the point of this study essentially is we have a treatment option for our HIV patients who have end-stage renal disease. This drug will work. So, I mentioned reinfection, and that's certainly a concern, particularly among our IV drug users. The HIV-infected patients, 65% of IV drug users will have hepatitis C co-infection. Well, is it actually worth it to treat people who are using drugs? They looked at people who were enrolled in opioid agonist therapy, so like methadone type programs, and evaluated what the efficacy rate would be in these participants. So they actually enrolled 300 participants. They were randomized to either start treatment immediately or wait and start treatment after 12 weeks. And this graph here shows the percentage of people who were taking some kind of illicit substance. Now, you can see that this number is, on average over the course of treatment, whether immediate or delayed, about 60%. Mostly marijuana. Well, a lot of people were on marijuana. I think that's the triangle there. That's about 30%. But you can see 45 to 50% of people were on non-marijuana illicit drugs. So still a very, very high drug use, even though they were in these maintenance programs. Overall, the sustained virologic response rate was 95% in genotype 1A, 93% in genotype 1B. Adherence assessment showed that 95% or 96% of people reported taking more than 95% of the doses. So even though they were using illicit substances, they were still adherent. There were 6 recurrent infections, so essentially reinfections, and 3 of those actually resolved spontaneously. So the people who argue like Texas Medicaid requires a negative drug screen before they'll agree to treat people, before they'll provide treatment, that is probably, you can make a whole bunch of arguments, but their argument is that people aren't going to be adherent with their treatment. This study shows that that's not necessarily the case. So what about relapse and reinfection? We talked a little bit about that. There aren't a lot of options right now as far as FDA-approved drugs. The one study of co-infected people who were relapsed with sofosbuvir ledipasvir were retreated with ledipasvir, sofosbuvir, and ribavirin for 24 weeks. And essentially what you can see, 9 people were treated, so it's a pretty small study. But 8 of these actually achieved sustained virologic response. So it was a very effective treatment, even though many of these had the unfavorable IL-28B genotype, so they didn't have a strong host response to help with suppressing the virus. The CD4 count was all over the map. The median was 758, but it ranged from 158 to 1,625. There was one person who relapsed, no clear reason why. He was very adherent, yeah, they don't have a good explanation as far as that goes. So there are 2 new regimens that may be coming out. I don't know exactly when. I guess I could look at the FDA website to see what the latest update is. But one of them is this glucaprevir plus pibrentasvir. I wish they picked easier suffixes. So glucaprevir plus pibrentasvir for 12 weeks, and people who failed sofosbuvir regimens. And these are non-cirrhotic people. They failed some sofosbuvir regimen with either a protease inhibitor like samiprovir or with like a ledipasvir. And they were treated with this combination for 12 weeks. And a 90 to 100% efficacy rate was achieved even in people who had resistance-associated variants. That's what these mutations are that are associated with drug resistance. So very successful. And then this is probably the most exciting regimen to be coming out. Sofosbuvir, vilaprevir, and oxalaprevir, which is a little odd, 2 protease inhibitors plus a nucleotide analog. But essentially what they saw in looking at people who failed sofosbuvir regimens, 12 weeks of this fixed dose combination resulted in 100% SVR rate. There is one failure, actually, who had some mutations, and she had previously reported failed 2 other treatment regimens. So we haven't had a huge volume of people treated with hepatitis C. I queried some other investigators as far as what are the barriers that they see to people with HIV infection who are coming in for hepatitis C treatment. And these are some of the key factors. So from the interferon ribavirin era, people who did not respond to treatment were people who missed clinic visits, who reported drug and alcohol use, who had untreated HIV infections, and who were of Black race, again, with that whole genotype interferon factor. And I think as far as the untreated HIV infection, I haven't, I generally take it, I won't start someone on hepatitis C treatment before I start someone on HIV treatment for a couple of reasons. One, first, HIV is going to kill them faster than hepatitis C will. Two, I'd like to see them show adherence to HIV medications before starting them on hepatitis C. Three, all of the studies that have been done were done in people on treatment with suppressed viral loads. And four, I'd like to not start them on medications simultaneously, so if they develop side effects from one regimen, we know whether it was the HIV meds or the hepatitis C meds, and we can adjust medications accordingly. But I like, particularly for some of our patients with HIV have some difficult socioeconomic and psychosocial backgrounds that may preclude excellent adherence to medications. And if they can show that they're adherent to one pill once a day, the HIV medications, I think it bodes well for their adherence to hepatitis C treatment. So among reinfections, there's actually overall a 2% reinfection rate based on a study of over 2,000 people treated with type 1 interferons. And the median time to reinfection was 3 years in the study, but the rate was twice as high in HIV-infected people, so on the order of 4 to 5% reinfection rate among HIV-infected people. And as I mentioned before, men who have sex with men are at higher risk for reinfection as well. So hepatitis B, this has been a huge kind of caused some people to have some shell shock recently with the direct-acting antivirals, and that 29 cases of hepatitis B reemergence, reactivation after starting direct-acting antivirals for hepatitis C have been reported. This is over the course of 3 years. So in the scheme of things, about 1 million people worldwide have been treated for hepatitis C with these direct-acting antivirals. So 29 out of 1 million, it's a pretty low rate, but still, this resulted in 2 deaths, 1 transplant, 6 hospitalizations, and 10 people stopping their direct-acting antivirals. People have their theories. Perhaps hepatitis C is a chronic viral infection, is stimulating type 1 interferon production and stimulating general host responses that are helping to keep hepatitis B in control. And so once you get rid of the hepatitis C, that host response isn't there and the hepatitis B flares. But regardless, if you look at people before they started hepatitis C treatment, 1/3 of them had, more than 1/3 had undetectable hepatitis B DNA or not reported hepatitis B DNA, but no reported hepatitis B surface antigen status. So that wasn't tested. 31% had detectable hepatitis B DNA. 21% had positive hepatitis B surface antigen, and actually 10%, which is only 3 people, had negative antigen and negative hepatitis B DNA levels. So the other factor is that these recurrences of hepatitis B reactivation occurred about 4 to 8 weeks after starting direct-acting antivirals. So what do we do with this information? I mean, certainly it's rare, but it's something you don't want to be the person who has a patient who ends up in the hospital requiring a liver transplant because their hepatitis B flared. So we screen everybody for hepatitis B surface antigen and antibody. If they're antibody negative, they should be vaccinated, no doubt. So if they don't have hepatitis B surface, if they have hepatitis B surface antigen, and it's essentially you put them into the general ASLD guidelines, the American Association for the Study of Liver Disease guidelines, and you treat them according to their DNA levels. Now, of course, if they're on a tenofovir or emtricitabine containing or lamivudine containing regimen, they're in pretty good shape in terms of keeping that hepatitis B in check. Now, if they're core antibody positive but hepatitis B surface antibody negative, then the question is, what do you do? Well, according to this guideline from the ASLD, we don't know what to do. According to the guidelines from primary care management of HIV-infected people, we check hepatitis B DNA. So that's what I would say we do. So what about drug interactions? That's certainly something to consider. And here's a list of many commonly used antivirals on the left and the FDA-approved hepatitis C medications across the top of the screen. The green indicates drug combinations that are fine to use. The yellow are caution, and the purple are drugs that you should absolutely not co-administer. And I put in red drugs you can use, no problem, don't have to think about. Tenofovir, alafenamide, dolutegravir, raltegravir, no problem. Emtricitabine and lamivudine are on here, but there are no drug interactions with those as well. The rest of the drugs, though, you can see there are some concerns. Tenofovir, diproxyl fumarate, in particular TDF, is one that turns out ledipasvir, which is part of that big blockbuster drug, can increase tenofovir concentrations in the TDF formulation and increase the risk for nephrotoxicity. So particularly when co-administered with protease inhibitors. So that's one consideration. And you can see the rest for yourself. But essentially, if people are on integrase inhibitors and a TAF-containing regimen, they're good. And so that's what we put most of our people on who we're going to plan on treating for hepatitis C. So what about other medications? Well, acid-reducing agents actually interfere with several of the NS5A inhibitors, so ledipasvir, vilpadosvir. They prevent the absorption of these medications, so that's something we always have to ask, not only about prescriptions, but over-the-counter medications. Very important to ask. And also St. John's wort interferes with several of the hepatitis C medications as well. So it's important to not only ask about over-the-counters and so forth, but to ask about herbals and supplements. Birth control pills, of course, ritonavir interacts with that. And some of the anticonvulsants and statins as well. There can be an increased concentrations and increased risk of toxicity. So I mentioned decladisvir, and essentially that this can be dose adjusted because of, with regards to drug interactions with antiretrovirals, but it is contraindicated again with some of those other drugs, statins, anticonvulsants, St. John's wort. And renal impairment. So grazoprevir and elbasvir, so that's the one drug that's no adjustments needed regardless of renal function, even on dialysis patients. The other drugs, generally speaking, either don't have safety established for people with creatinine clearance under 30 or have not been shown to be safe. So adverse effects, these are very well tolerated medications. Every single one of them, package insert, leading side effects, headache, fatigue, nausea. However, a lot of people experience fatigue and nausea without hepatitis C treatment. And some people even say their fatigue's better once they get started on treatment. The rate of treatment discontinuation is exceedingly small in any of these large clinical trials. It's just, these are very, very well tolerated drugs. The key issues we run into are with the drug that's currently first line by Texas Medicaid, so ribavirin. It's teratogenic. It also can induce hemolytic anemia. And as a consequence of that, it can predispose to myocardial infarction, both fatal and non-fatal. So we avoid it in pretty much anyone we can petition to avoid it in, but certainly anyone who has a history of cardiovascular disease or anemia. And then the paritaprevir, bidosvir, desabovir combination, that actually precipitated decompensated liver failure in patients who have more advanced cirrhosis to begin with. So it's contraindicated in those people with Child's class B and C. As far as monitoring, depends on who you ask. I think I'm a little more vigilant than the hepatologists. I think we're used to kind of keeping a closer wraps on our patients, but generally speaking, and also because of the risk of adverse events and side effects, we want to ensure adherence and people are doing well. So typically, I usually see people about 4 weeks after starting treatment, make sure they're not having side effects, check their labs. Most people at this point will have undetectable hepatitis C RNA levels. And in fact, most people will have undetectable levels even 1 week after starting treatment. And they just suppress really, really rapidly. More frequent monitoring is certainly indicated if they're on ribavirin, so looking for evidence of anemia. Actually, it's recommended to check weekly. And if on the paritaprevir multi-drug combination regimen, it's recommended to check liver function tests during the first 4 weeks weekly to make sure they're not decompensating. So some take-home points. Hepatitis C affects 25% of HIV-infected people in the U.S. Chronic hepatitis C is a major driver of end-stage liver disease in people with HIV infection. Sustained virologic response rates are very similar across, regardless of HIV co-infection. Reinfection after a cure can occur, but it's actually pretty rare. And this hepatitis B reactivation can occur and actually be fatal. So screening for hepatitis B infection is essential before starting treatment. And we have to consider drug interactions, particularly with antivirals, and over-the-counter medications. And with that, I'm happy to take questions. All right, thank you all for your attention. There's mud.
Yeah. You answered all the questions before they were asked.
Apparently. I usually get some questions.
It's a win. Take that one to the bank.
I know. Sometimes I wonder if that means anyone was paying attention, but
no,
people kept their eyes open.
Yeah, very, very.